just takes a second. So, all right. So we are now recording. So welcome everyone to the Medical Corps Symposium lecture series that's been ongoing for about a year now. So thank you all for participating, and thank you so much, Captain Lin, for volunteering to give this presentation today on some of your experiences with Walking Blood Bank and just some of your operational experiences. So just to introduce Captain Lin to anyone who doesn't know him, I think especially everyone in the internal medicine community does know you as the specialty leader, since you communicate with them on a regular basis. You are also the third MLG surgeon right now, but this summer you will be transitioning to the third MEF surgeon as, instead. So I just wanted to say thank you again, and I'm turning it over to you.
All right, great. Thank you, Jen, for that introduction. I think I'm going to turn off the video here just so that we have, so I have good bandwidth out here from Okinawa, and there's no lag. So I'll do that right now. Once again, if anybody has any questions, feel free to throw it into the chat, or you can text me if you have my number. I'll be happy to answer any questions throughout the presentation, or we can save it for the very end. Once again, like I mentioned earlier, I think this is a great, relevant lecture in terms of what where the Navy and the Marine Corps is headed in the next few years, with the whole idea of this distributed maritime operations, the EABO concept, prolonged casualty care. A lot of that, walking blood bank, a lot of that was we experienced here, and there's a lot of great lessons learned. I know I see some people from MRD here and from the fleet. So, a lot of the lessons learned from this was introduced in many of the mass casualty bills that have been changed for surflant on the big deck amphibs as well. So I was the SMO on the USS Baton from 2016 to 2018, and this mass casualty occurred in August of 2017. All right, next slide. All right, cool. So, just kind of a quick intro. So the USS Baton, which is an LHD, we were deployed to the 5th Fleet during Operation Inherent Resolve. It occurred in August of 2017. We had a UAE, United Arab Emirates, Special Operations 60 with 10 people on board that crashed during operations. 4 people died immediately from the helicopter crash, and the remaining 6 people were transported back to the ship when they were about 12 hours after the actual crash. This was the largest walking blood bank activation since World War II. Actually, in one of the papers we had published, we had written down largest walking blood bank activation since Vietnam War, as we couldn't find anything published since then. And I think the Wall Street Journal, which published a article on this mass casualty, talked about it being the largest walking blood bank activation since World War II. So because the Wall Street Journal went with that, I'm going with the largest walking blood bank activation since World War II. So next slide. So this is the actual article from the Wall Street Journal. Pulled this up, and you can see right here the title. It says, a secret U.S. rescue in Yemen played a role in Middle East peace deal. So I think many of you guys may have heard about the Abraham Peace Accords, but essentially, one of the special operators from UAE was the Crown Prince was the nephew of the Crown Prince of UAE, and we saved his life, and that created a lot of really goodwill, as they say here, building a reservoir of trust that helped lead to the recent agreement, which was the Abraham Peace Accords. So it allowed the U.S., Israel, UAE, and Bahrain to sign the peace accords, Abraham Peace Accords, which is monumental. I mean, really, it's, since the Israeli-Egypt peace accords, this is really the next biggest peace accords that we've had. So, I think this, politically, this has played a great role in that respect. So, I do share that this is has political implications, what we were able to do, and a lot of the stuff we do in the Navy does have that. Next slide. All right. So this is so you can see here the Crown Prince is MBZ is standing over here on the far right in this picture, and his nephew, he actually was he fractured his he broke his back and ended up paralyzed from paralyzed from the legs down, and so he is wheelchair bound. So I remember when he was sitting in our ICU on the baton, we were like wondering, oh my gosh, how is this 20 something year old able-bodied male who's a special operations guy going to be received when he got home? After we saved his life, how was he going to be received? And we were concerned, like many of these countries, they don't handle like handicapped family members well, especially in the royal family. But it was just amazing for me to see this picture, because it showed me that they really did care. And so UAE and Saudi Arabia played a big part in the war in Yemen and stuff, and they really use this. And you see, in articles later on, you'll see like MBZ and the Crown Prince and the royal family of UAE, they really use the nephew to show, hey, we don't just hire mercenaries to fight our wars. We actually give our own flesh and blood to participate in this war. And so, it's just great to see this picture. And I put this in here because it shows that this what we did had huge political implications, international implications throughout. So once again, that's why I put this in here. All right, seeing no questions, next slide. All right, so kind of just to give you a little bit of a background of what we were doing. So back in 2017, we were essentially sitting out here off the coast in the Gulf of Aden, just south of Yemen, just basically doing gator boxes out there. You can see the Horn of Africa, Ethiopia, Somalia. Let's just say this, we were doing a lot of operations in this area in Yemen, Somalia, operating out of Djibouti. And we did, a lot of these operations did occur during, new moons, when it was dark, and it was a lot of medical support. And I will just kind of throw this out for Navy medicine just to let people know. There are many times we would be sorting an operations up in Yemen, right? And we would be too far away to support an operation down in Somalia. The line community, they have a very strict rule. If they cannot get a roll 2 within an hour of operations, they will cancel operations, right? So a lot of times we had multiple surgical teams on our ship, and we would fly some of the surgical teams. They would try to fly them off into either Somalia or somewhere else to try and support another operations down south. And if we could not support with a roll 2 within an hour of any operations, they would actually cancel those operations and move it either later in the month or a couple days later when we could get down there to support. So, for everybody thinking like medical isn't important, we are important. We are very important. They care about making sure our Marine sailors, soldiers have direct access to top level roll 2 care. So I just send that out there on this slide to say, hey, these are large geographic regions, and our ship would move from location to location just to support this. All right, no questions here. Next slide. So this is kind of back in 2017. This is kind of the layout of Yemen. There were really 3 different factions that had control of Yemen. Over here on the far left, so the red, actually, we'll start with the red. Those are the loyalists. These are U.S. friendly forces. Okay, so like the Gulf, so the city of Aden, that was U.S. allied loyalists, and then everything to the west in that green section there is probably the most mountainous regions of Yemen, and that is actually where most of the people actually live, and that is where the Houthis had control. And so, and then the blue area there is where Al Qaeda had control. And so what they ended up doing was we would actually we were supporting Saudi Arabia and UAE as they came in to take out the Houthis and Al Qaeda. The way they had divided, we have a hot mic. So the way they had it divided up is Saudi Arabia came in from the west and would hit the Houthis, and then the UAE came in through the eastern section and then basically took out Al Qaeda. Obviously, the Houthi section, the Saudi Arabia and the Houthis was much more publicized in the press, and that was what was mostly talked about. But the UAE, as they came in through to take out Al Qaeda in the east, they essentially would say, hey, we'll give you money to switch sides and join us, and if you don't, we'll just come in, we'll just kill you. And it made it, the decision was fairly easy for most of these guys. They just took the money. So, but there were very high value targets that they would go in and come after. And so that's where a lot of these special operations missions occurred with UAE. They would go in there and take them out. We'd see, super video of them coming in and taking helicopters and stopping moving vehicles and taking high value targets out. So it was very kinetic, and it was very real even in 2017. So just wanted to kind of give you that background as we kind of move on. All right, seeing no questions, let's next slide. All right, I threw this slide in here just to kind of give a background on the LHD, the USS Baton. So there's essentially, in generalities, there's really three different classes of of amphib ships in terms of size. So the LHD, LHA now, they have a few LHAs now, is the largest of our amphibious assault ships. This thing's 40,000 tons. So just to give you an idea how big this is, 40,000 tons is the size of some Russian carriers, some Egyptian amphibious assault ships and carriers, British carriers, Chinese carriers, right? So some of our like medium-sized ships, like the LHDs, are as big as other nations' carriers. So it just gives you an idea how big this is. The way to think about this is it's essentially a large, helicopter assault ship on the deck. And then at the very back of the ship in this picture, there's a well deck, right? So they can actually lower the draft of the ship and fill the well deck with water. So you can have large LCUs, assault land vehicles, troops onto the shore. So it is truly a beautiful ship in terms of amphibious capabilities, as you can go from air and land to assault. And this is the reason why the Marine Corps loves these ships, and they're asking the Navy to buy more of these. One of the things on these ships, if you're sending Marines ashore to assault a beach or do an amphibious assault or any type of operations, you'll oftentimes receive casualties. So these ships are specifically designed to receive casualties. You've got 4 ORs, 15 ICU beds, a 45-bed medical ward, which is expandable to hold up to like 400 plus troops, casualties if you need to. We got X-ray and lab capability. We got a frozen blood bank. We got a walking blood bank as well. and we can receive casualties from surface or air. So that was the ship that we were operating out of. All right, next slide. So, one of the things, so I will confess, I am a cardiologist, right? So, and being in kind of internal medicine, from internal medicine background, I looked at the mass casualty build that was used for the baton at the time, and I was like, God, this thing looks like it was written like 20 years ago, and I was like, man, things have progressed. And one of the things I did when I first got the ship, I was like, all right, let's go back to the basics, right? Kind of like Elon Musk style. Like, let's break this down into the basics. If we're dealing with trauma, what are the key things we need to know about this, right? And in my limited trauma training, I did know about the lethal triad, right? So the trauma lethal triad is hypothermia, coagulopathy, and metabolic acidosis. So one of the very first things I was like, okay, well, let's start tackling and seeing if this mass casualty build addresses all of these different things, right? So if you look at the ship, the coldest rooms on the whole ship outside of the IT offices is actually the ORs. So on a ship, in order to cool the rooms down, we have this thing called fan rooms, right? And these fan rooms, they put chill water through the pipes and cool off a space. And normally these spaces are like, 5,000 square feet, to 10,000 square feet, depending on how big or how cold you want it. But in their original design on these ships, each OR, which is probably no more than like 150 square feet, has its own individual fan room, right? So I was like, dang, they've really made a huge effort to cool these things down. So even in Fifth Fleet, where it was just hot as all get out, these rooms were still cool to like 60 degrees or more. And as all of us know, like that is just way too cold. So, I literally we looked at, heating these rooms up with, you ever seen the gate guards with the blowers, the gas blowers and the electric fans? So we looked at using those to heat up the rooms, right? The Chang on the ship thought I was totally crazy. And I was like, no, I'm totally serious. I need these rooms at 98.6 degrees. I need these warm, hot, not warm, hot. He's like, all right, doc, gave me that look. And what we ended up doing was, obviously we couldn't put a gas furnace blower in there for carbon monoxide reasons. And then the big old electric fan, radiating fan heat was not a workable solution because they had the wrong plugs. I was looking, we had 120 volts and there were 220 volts. So it just wasn't going to work. So eventually we ended up pulling up the plans and we looked at it and we were like, oh my gosh, each of these fan rooms, each of these ORs has its own fan room. And we figured out how to replumb each of these fan rooms so that we can redirect or turn off the cooling to each of the rooms. And so once we did that, we realized it would take literally like 7 to 9 minutes for these rooms to heat up from 60 degrees up to body temperature. And so we routinely would then practice that in all of our mass casualty drills. There was someone assigned to go and run to each fan room and identify. And these fan rooms were like all over the ship. They weren't just like adjacent to medical. They were like 2 decks up, 20, 30 frames forward or back. So, it was literally something we had to drill and make sure that this was part of our exercises so people would go there and heat it up. Whether or not, heating up a room from 60 degrees or 90 degrees saved these guys' lives, I don't know, but I think every little thing probably contributed, right? So let me talk a little bit about, I'll switch down to 3 here, metabolic acidosis, right? So metabolic acidosis, that was probably the easiest one of the 3 to treat. I mean, if you got a metabolic acidosis in a trauma patient, well, you need to treat the trauma, resuscitate. We had bicarb. So that would be something that was easily handled, and we didn't really have to address that. Coagulopathy, Now that was something that we did have to address. So on the ship, we had a 450 unit blood bank, right? Frozen blood bank, 400 units of packed red blood cells, 50 units of frozen plasma, right? So, if you break down blood, what are you missing? You're actually missing platelets, right? So that was something that I worked very, very strongly to try to get platelets on board. I had actually deployed to Afghanistan with one of a blood banker, and he actually ended up being the BUMED blood banker. And so one of the things that we were trying to pilot was to bring a plasmapheresis machine on the ship so that we could regularly draw blood, draw platelets and stuff. And I thought it was also a good idea to do, because this way would force us to actually draw blood regularly on the ship and get us kind of through the actual routine of doing, like, drawing blood using 16 gauge needles and whatnot. So obviously a week before we left, everything fell through. And so then we're back to, well, I only have 2 out of 3 components, and it's not even the right ratio. It's not a 1-to-1-to-1 ratio. And so, the ship actually had a walking blood bank, but it was only 2 phlebotomy stations, right? And some of the lessons learned from the previous ship out there that we were placed in Macon Island, when we went out there as an advance party, we realized that, if you look, I think in 2017, there was a Navy SEAL who got shot and multiple injuries out there. And it made me realize, like, oh my gosh, we're really going into some real kinetic activities. I was like, hey, we need to increase the number of walking blood bank, stations, phlebotomy stations, from 2 to 6. So that's what we eventually did. And we built a very big, robust program. This was before the Marines had Valkyrie, and we had not fully adopted the Army Rolo program. So by adding 6 phlebotomy stations, it really did help. And at one point in time on the ship, we were drawing like 12 units of blood and transfusing 12 units of blood every 30 minutes on some of our casualties. So, all right, I see some questions here. Let me see here. I see Captain Sullivan. So he has a comment. He said, Captain Sullivan has a comment. He says, we had a ERSS on our LPD, and they wanted the ORs warmer, and we were able to MacGyver our way to engineering it too. It wasn't part of the standard procedure, though surgery teams weren't on board. So yeah, so Captain Sullivan, that's a great comment. And heating the ORs was not standard operating procedures, but they are now in the mass casualty, kind of like the procedures for at least the LHDs. And I think that's a great comment, because as we go out into the operational community, we see this all the time, where there's things that just doesn't quite make sense. But I was like, but medical literature says we should heat these ORs up. So, I challenge all of us who are going out there to say, hey, look, we need to look at these procedures, and we need to ask questions. And that intellectual curiosity is going to help us improve the medical operational community. So, and then, so Commander Driscoll had a comment. He said, has the OR temperature concern been sent to Surf to spread these policies? Yes, it has been. So after this mass casualty was done, I think we rewrote our mass casualty, and I think a lot of the mass casualty bills were copied, or I was told, people were told just to adopt the new Baton mass casualty and use that as a basis for the future ones. So, all right, I think that should be all the questions regarding this. Actually, you know what? Somebody else had a question about humidity. So yes, humidity was a big issue with the when we heated up the ORs. So when you heat it up and cool it down, there would be a good amount of condensation. So yes, it was something that we knew about, because the air conditioning was dry and cold, and when you heated it up, it became hot and humid. And so when we transitioned it back and forth, it became issues. So we would, we would only probably do that maybe once or twice a week. And then we would always come through and wipe down the rooms if humidity control became an issue from heating up the rooms too often. So, all right, next slide, please. All right, next slide. So what I'm going to do is because we're a bunch of doctors here, most of us are doctors here. I'm just going to kind of talk a little bit about the actual casualties and stuff. So once again, the aircraft crashed in the afternoon early afternoon, and because it wasn't a U.S. bird and U.S. troops, there were some difficulties getting these patients to the beach where we could eventually go there and pick them up. So a lot of these guys were like dragged. I saw some of these pictures. I mean, one was on a stretcher, but another one was on plywood. Another one was on a mattress. They were thrown on the back of pickup trucks, and they were driven out to the beach where we finally met them. So about 0100 at night, it was like 1 a.m. At night is when we went out to meet them. Our ship actually at the time had 3 surgical teams. It just kind of give you an idea how concerned they were and supporting all the operations in Yemen and Somalia. Is like we actually had 3 surgical teams. So the surgical team that is attached to the baton through the FST, or it is the FST. I'm sorry, it's the FST surgical team, and the other 2 teams that were attached was an ERSS. And then also we had another tier 1 surgical team called the SRT. If many of you guys have been stationed in San Diego or Portsmouth, you've worked with these guys either as surgeons or ER doctors. And essentially this is a tier 1 JSOC surgical team that has Role 2 capability with just four people. So everybody out there saying that, Role 2 can't be done with less than 10 people or 30 people or 40 or 50 people, that isn't true. The size of the team does make a difference in how long you can hold them for. But we can do Role 2 care with a small, highly trained team. So I do want to share that with you. All right. So by the time these patients did arrive, what we did notice was this first patient was he was one of our pretty unstable patients. We were able to get x-rays on him. He had an unstable pelvis. He was hypotensive. He was given some ketamine. He was given a humeral IO and given 1 unit of blood. So what we ended up doing was we sent out the SRT surgical team actually flew out in the 22 to meet them at the beach. They did a quick triage, threw them on the 3 birds, and brought them all back to us. So during the resuscitation, this patient actually ended up not requiring any surgery. He was hypotensive, 90/60, tachycardic. His pelvic x-ray showed a fracture. Why don't you go ahead and show the next slide? And during the and once we received him kind of in the ER, his pulse got down to 80/palp, heart rate jumped to about 120, and he did get 6 units of blood totaled in his resuscitation. As you can see here, there's, the SI joint is displaced, and, I think it's a pretty obvious pelvic fracture. We ended up putting a pelvic binder on him, and that was able to hold. Yep, thank you for pointing that out, Jen, right there. And we were able to stabilize him, and he didn't require any surgery. What is interesting, go back 1 slide, Jen, please. We gave him 4 units of packed red blood cells, right? And, and I'll be honest with you, in 2017, I was not a huge fan of whole blood at the time. I just wasn't sold on it. I think many of the surgeons on our teams were kind of like, but I'll tell you, when he did eventually get some fresh whole blood, and I think he got additional 6 units of fresh whole blood. It was miraculous. Like the blood pressure would stabilize, heart rate would come down, and I think although we think we understand everything that's in plasma and stuff, I still honestly believe there's probably still stuff in fresh whole blood that we don't even know exists that has capabilities. So anyways, by giving the fresh whole blood, whether it was just having the platelets or just having fresh plasma, that made a huge difference and really stabilized his blood pressure, where we were able to just watch him for the remaining 48 plus hours and not require much else from him. So this was a huge win. And we were able to manage him with just our STP ER doctor on the from the MU. So next slide. Let's see here. I have another Commander Foster has a comment here. Okay, so Commander Foster had a comment here. It's worth sharing. He was commenting at to Captain Kubek, basically saying ship design is oftentimes 10 years before the keels are laid, so it's often hard to keep up with changing guidelines and redesign the ships to adopt warming up the ORs as part of the design. So, but I think in the future, that's definitely something we need to look at, being able to heat up our ORs on some of our trauma casualty receiving treatment ships. All right, next slide. All right, the patient number 2, pretty straightforward, had a left lower extremity deformity, fairly stable. Blood pressure is about 100/60. Heart rate was a little bit tachycardic. Go ahead and show the next slide. So, as a cardiologist, I was able to make this diagnosis. But obviously, you see a comminuted tib-fib fracture here. So obviously, we were able to stabilize this. He ended up requiring a washout and did just fine. All right, next slide. So this patient here, patient 3, this is probably the most interesting case here. Just to kind of give you a background, this guy was actually probably the healthiest of all of them immediately after the crash. So the helicopter actually crashed maybe no more than 1,000 yards from one of the local villages in Yemen. And when they crashed, actually, this patient here actually got out of the bird and grabbed some of the other casualties and set up a perimeter around the helo to kind of protect the helo and the crash site. So, he grabbed, 240s, and other weapons to kind of support the, so he was pulling people out of the bird from the wreckage. So, and all he had was a simple facial laceration. That was his only injury, actually. So this is a great example of how, us teaching TCCC and doing TCCC correctly can protect from future, like, worsening injuries. So during the 12 hours to kind of get back from the actual crash site to the beach and stuff, he actually ended up losing a lot of blood. When the SRT team was there and they actually assessed him and brought him back onto the bird, they recognized that this was the sickest patient. So when they were putting the patients on the bird, they stuck the CRNA and the surgeon on this patient to monitor him on the flight back. On the flight back, they lost vital signs. He basically went into a respiratory arrest in the back of the V-22. The CRNA says, so he went ahead and intubate, was preparing to intubate this guy. The CRNA, when he looked, all he saw was blood in the back of the throat. This guy had blood everywhere. And so, in order to find the airway, he pushed on the chest, looked for some bubbles, intubated it based on where he saw the bubbles, and got it on the first shot. amazing intubation, considering it's in the back of a V-22 at like 2 a.m., new moon, dark, nothing going, I mean, that is truly a varsity intubation. So after that, the trauma surgeon quickly reassessed and said, "Hey, I don't have a pulse." And he's like, "I don't have a femoral pulse." And the anesthetist was like, "Okay." He checks the carotid, says, "I don't have a pulse either." So the surgeon basically sets up and does a left anterior thoracotomy. He cross clamps the aorta and starts cardiac massaging the patient. So he's able to cardiac massage this patient all the way back to the ship. They actually stayed with the patient the longest, and we moved all the other patients out into the flight line BAS triage, flight deck triage, and then we moved everybody down. We kind of because the patient was relatively stable, being cardiac massage and stuff, once everything was kind of set up, we had the OR set up, and then we moved this patient down into the OR afterwards. I do have a pretty funny story related to this, because we did a lot of drills. We used a lot of the ship's company to be stretcher bearers. And I remember there was a YNSN who, was maybe 5 foot tall, 100 pounds, who was one of our stretcher bearers, one of our great stretcher bearers. And she actually ended up having this patient. And when she pulled that patient in, she was like, so they call me Top Doc on the ships, like, "Hey, Top Doc, hey, is this a drill?" as the surgeon was, cardiac massaging the patient in front of her. And I said, "This is not a drill." And she says, "Oh, I don't feel very good." And I said, you need to go sit down, because right, if you pass out right now, I don't know when we're going to be able to get to you. So we had her sit down. We found another stretcher bearer. But it just goes to show, like, hey, we work very closely with the ship, and having stretcher bearers, it was a full team exercise training for these mass casualty bills. So finally, when we got this guy down into the OR, we were able to resuscitate him enough. His initial vital signs in the OR was blood pressure of 65/30. His heart rate is 130. His temperature was 34 degrees. His pH was 6.7, which is on the scale not good. And his lactate was close to 15. So this guy was absolutely, absolutely sick. So they took him back to the OR. And they went ahead and did exploratory lap. They resected the part of the small bowel. He had a small mesenteric avulsion, and then they put in a trach. And during the OR resuscitation, he got 8 units of packed red blood cells and 8 units of fresh frozen plasma. So he hadn't received any fresh whole blood at this time. Go ahead, next slide. And then if you kind of look at the other stuff they did in OR, they worked on him for almost 3 hours initially. We actually had all 3 surgeons, all 3 anesthetists kind of working on him. Believe it or not, all of the other patients we were able to kind of to manage with just, the ER docs, our ICU docs. And so there wasn't an urgency, but I was keeping an eye on whether or not, like, hey, maybe we should call this and work on some of these other patients. But no, the other patients were, we had urgent surgicals, but they weren't like urgent surgical like this. So we made a decision to continue and let us continue to resuscitate this patient. So this guy eventually did not do super well. After about a couple hours after the initial surgery, his blood pressure started dropping, started having issues. And so we took him back to the OR, did an open thoracotomy, and he had just blood in his pleural space. And so we put in, they did a thoracotomy, put in some chest tubes. And then this is when we started resuscitating him with actually whole blood. Believe it or not, of all the patients, he was the only one with A positive blood. And our walking blood bank list only had like 12 people with A positive. So by the time we were drawing blood on this guy, he eventually got 44 units of blood total. We had actually woken up most of the ship at like 3, 4 in the morning and had corpsmen running down to each of the berthing, marine berthings, waking up, yelling, telling people, hey, if you've got A positive blood, we need you to get down to dental immediately to get your blood drawn. And, within like 30 minutes of that call, we had up to like 70 people lined up willing to give blood. And so after we started doing that resuscitation, we got some new labs. His pH came back. It was 7.2. Lactate was 6.1. So you can see significant improvement. One of the jokes that we had with this patient was, he came on board as a Emirati, but he left as a devil dog with all the blood he ended up getting. So next slide. So one of the interesting things is, people are like, why are we doing washouts on these patients? So the thing is, the problem with the Medevac for these patients was we had issues because these were Emiratis, and every single patient movement that we were doing went from there to Djibouti, which was in the Horn of Africa. And because of that, the Djiboutians did not like the Emiratis and didn't want them. And so, as soon as these patients arrived, like a good intern, you always worry about disposition. And we were trying to figure out where to send these people, right? Where do I got to get them off my ship. Otherwise, these guys are all going to die. And as soon as I found out that I couldn't send them to Djibouti, I was like, we've got a problem. So I actually made a phone call to then, Rear Admiral Vi, who was then the CENTCOM surgeon, and called him up. And I was like, hey, Captain Vi, who's the captain then, hey, I got an issue. And he's like, oh, I know about it. I was like, hey, what do you need from me? I was like, I need you to send down a C5, a CAPT team from the Air Force. And he's like, done. And so, a lot of times, we depend on a lot of these relationships to get stuff done, but that was super duper helpful. And he was able to get a bird down to us within 48 hours. But because of that, I had no idea whether I would need to hold them for 48, 72 hours. And so we had to proceed with washouts on all of these patients because we had to hold them. We held them for at least almost 48 hours. And so that's why we had to redo the washouts and reopen the lap, and kind of really just kind of had to take all these guys back to the OR. So anyways, eventually he stabilized. pH was 7.3, which is totally acceptable when you start at 6.7, a lactate of 4, which is absolutely amazing. So next slide. So this is his chest. This is his chest X-ray with both bilateral. So you can see, he obviously developed trolley and taco from all the blood we gave. These guys became big. Typical trauma is very simple in terms of the ventilation, but these patients here, because of the amount of blood we gave them, they all kind of developed, acute lung injury or acute congestion from the fluid, and they became very challenging to ventilate eventually. We had them on like PEEP of 15, FiO2 of 100. It really became quite a challenge. So anyways, you can see his tracheostomy too. All right, next slide. This slide here will actually show you, this was really like one of his major injuries was just this chin. So that's his chin, and that's his laceration that he suffered there. So you can see, like, it's super critical, like, to make sure we, wounds that we can compress, we need to compress and make sure we get good dressings on. And the non-compressible wounds is really where we need the role to help out here. The crazy thing about that open thoracotomy and the intubation on that in the back of the V22, all of that done just to kind of really do another shout out to the SRT and the surgical teams. I mean, they did that in the back of V22 at 2 in the morning on really a 9-minute flight from shore to ship. So it was a pretty amazing a save here. So any questions about that? All right. The next 3 patients, next slide. We should be able to fly through real quick. So patient 4 and 5 essentially are the same. They both had normal vitals, had cervical spine tenderness, and lumbar spine tenderness, and they both had spinal injuries, and both were paralyzed from the leg down. Next slide. The same thing. Next slide. So one of those two patients was actually the prince of UAE, and that was the one we ended up saving. So patient number 6 here was a open tib fib fracture. He ended up having normal vital signs. Once again, had some spinal tenderness and a step off, decreased lower extremity, paralyzed from the leg down. We ended up doing he actually ended up developing compartment syndrome, and we had to do a 4-compartment fasciotomy, and then we fixed his, did external tibial fixation. Next slide. And this should be a picture of his x-ray here. So you can see he ended up getting a fasciotomy for that, and he ended up getting some blood as well. All right, next slide. And that's the fasciotomy. It was actually pretty cool because, you know, going in there, I don't know if you've ever seen a true fasciotomy, but when they cut that open, you could just almost hear like the tissue sigh in relief of that pressure being relieved. I mean, it was just like, I don't know if I imagined it or not, but it was just like you could just feel the pressure being released as soon as the surgeon cut it open. It was absolutely amazing. So good job on them for that. All right, next slide. And then just kind of to reiterate kind of the amount of blood we drew over 70 units of whole blood, but this is what we ended up giving. So patient number 1 was a pelvic fracture, 6 units was all component, and then the 6 units of fresh whole blood. Like I said, that fresh whole blood really did amazing things to stabilize the patient in terms of vital signs, just the oozing, the bleeding, all of that seems to improve when you give fresh whole blood. So he got a total of 12. Patient number 2 was a tib fib fracture. He got 4 units of whole blood. And then the patient number 3 got 44 units total, 8 of component, and then 28 of fresh whole blood. And remember, there was at one point in time, we were literally drawing 12 units of blood every 30 minutes to get him enough blood. And literally it was draw the blood, run it back, because remember, we ran out of screened walking blood bank patients, right? So we were just taking anybody. We were looking at dog tags and going off of people saying hey, I have A positive blood. So we would run that back to the lab. We would test it real quick, confirm it's A positive, and then we would run, and then literally before the lab tech could even write A positive on the piece of paper, that blood was being run back into the OR and then chucked into the Belmont to be sent into the patient. And we did that 12 units for about 30 minutes to just kind of keep that guy alive during his second surgery. So great save. Patient 4 and 5 were the spinal fractures, and patient 6 was tib fib fracture and got 1 unit whole blood. New paragraph. Hitting 50 minutes here, so I'll try to wrap up. Next slide. All right, so just a couple of comments on en route care. Once again, non-US soldiers, we couldn't medevac for Djibouti, so we had to ask for a special CAPT flight from Landstuhl to come down. They ended up landing at an airport on the beach in Yemen, and then what we did was we moved the patients with V-22s over to Yemen in the middle of the night. On the flight deck, 2 of our patients developed respiratory distress due to oxygen tank issues. Actually, you know what? This might be worth sharing. Jen, can you forward to the first backup slide? So this is actually a pretty good lessons learned. I think it's probably worthwhile to share with some with y'all here. On the ship, if you look, that we have D tanks and H tanks. So D tanks, if you can look, is the 7th one. It's in the middle here in the picture. So it's a small tank. It carries, thank you. Yep, right there. It carries 400 liters of oxygen when pressurized. depending on what PSI. And the H tank is on the far right, okay? And that has 7,000 liters. So one of the things that I learned was, in a D tank is great for like patient transport between like an ICU and wards and stuff, because nasal cannula at 6 liters a minute will give you an hour. If you're on a face mac at 15, it gives you 26 minutes. So, as a prior flight surgeon, I just know like getting these oxygen tanks onto like an aircraft, these things are essentially like bombs on the aircraft, right? So in order to kind of like try to mitigate that risk, we actually put a whole bunch of D tanks on there, and really not really even thinking about how many liters and the use rate of these oxygen tanks. And so we had, remember two of these guys ended up developing Taco and Trolley, and they were on ventilators at 15 a P, 100 FiO2, and so that would be at least 15 liters. So we knew we were anticipating routine D tank changes, and so we would have multiple D tanks when we loaded them onto the bird for the Medevac out, we loaded on multiple D tanks. But switching them out essentially every 30 minutes or every hour or so just was too burdensome. And eventually the disconnecting and connecting and of the ventilator to the tanks, it caused them to lose PEEP and recruitment, and they desatted. I mean, these guys desatted into the 60s. And literally, as we were high-fiving each other saying, hey, we got these guys off the ship, two of them rolled back on into our ICU. And we spent another hour or so trying to get recruitment back, and we were able to get it back eventually. But then what we did was I took a bunch of our strongest corpsmen, loaded on like 4 H tanks, and chucked the H tanks onto the next bird of opportunity, and used that. So the H tanks has 7 liters, and that's 7 hours with 15 liters a minute. So that, the second time around, when we put them on H tanks and didn't have to like muck around with the vent and reattach and bag as we're switching stuff, the patients did fine, and all of them eventually got to launch stool just fine. All of these patients survived. Obviously, the patient with the open thoracotomy had a prolonged physical therapy and rehab, but all of these patients did survive. Can you go back to I think 2 slides, please? And so there are multiple publications that have occurred. I did mention the Wall Street Journal. So that is a lay press, and actually they had many of the details very, very accurate in that article. I was very surprised, and it was great. And then we published a more of a clinical case talking about each of the casualties. If you're interested in learning more about the individual casualties and how we managed it, the surgical techniques, stuff like that, we talk about it here with the joint. It was published in the Journal of Trauma and Acute Care Surgery. Ben Miller was our FST surgeon, Sue Clark was our ERSS surgeon, and Andy Kapp was our SRT surgeon. And then Joe DeBose is just a big name in, I'm sorry, Joe DeBose was our surgeon. Andy Kapp is a big name in the Joint Trauma Center community. And then the last article down here was published a little bit later. It mostly was talking about the prolonged stabilization, and it really talks more about distributed maritime ops, EABO ops. And, now the key word is prolonged casualty care, and that is what this article talked about in terms of what was done, how we manage the vents, and stuff. I do also have a after action report that I wrote up the day after or 2 days after this mass casualty. I'm actually happy to share that to anybody who emails it to me. I think a lot of great lessons learned. We go into details about the OR. We also go into details about whole blood and walking blood bank. and other issues like that. So, and and we also talk a little bit about supply as well. So if you all are interested in that, please email myself or Jen, and I'll be happy to send that stuff out to you. All right, next slide. And that's it for me. I will be happy to take any questions. I see Captain Hudson. Captain Hudson has a good question. Says, Captain Lin, outstanding presentation. Did you have any unexpected injuries or health conditions among the crew as a result of the mass casualty or related to it? Yeah, I think overall, I think our crew did well. I think we trained. I mean, I'm a little bit of a Nazi when it comes to training. I mean, we did drills like 3 or 4 times a week on the ship. So I think people were very used to it. We did make a big effort, and I talk about this in the after action report there about we made an effort to make sure our mental health assets and our embedded mental health made an effort to get out to the ship and talk about it with people because we were concerned about mental health stuff related to that. So, I did not see any major health conditions related to this mass casualty. So, all right. Seeing that there are no other questions and no hands.
Did anyone else want to ask anything? Please feel free to raise your hand. If you called in, please feel free to just unmute yourself and go ahead and ask any questions. We do have just a couple minutes. And thank you so much, Captain Lin. That was a fantastic presentation. All right, if there are no questions, and Captain Lin, did you want to say any last minute items?
Nope, nothing else to add. Thank you very much for your time and sitting through the presentation.
Yes, thank you so much, everyone, for joining. I will end the recording now.